All of us who have lived through this pandemic have our own sense about whether it remains an acute health threat or something less perilous. But experts at the World Health Organization this week gave their official perspective on the matter. With us now on that, in Breckenridge, outside Denver, Colorado, Dr. Stefan Barral. He is professor of epidemiology at the Johns Hopkins School of Public Health and a population health and family physician providing care in the shelter system in Toronto. And Dr. Barral, as I welcome you to the program, I know Johns Hopkins isn't in Colorado, and I know Toronto's not in Colorado, so what are you doing in Colorado?
Well, indeed, both my wife and I as clinicians work pretty heavy during the traditional holiday season, so this is our week off that we take in lieu of the normal sort of Christmas, New Year's holiday season. So we're here on holiday and enjoying it.
Great. Glad to hear that. All right, let's set this up with the following. It's 3 years this past Monday since the WHO declared COVID-19 was a global public health emergency. And here is that organization's latest pronouncement on where we're at. It says on Monday, the expert committee determined that COVID-19, quote, continues to constitute a public health emergency of international concern, and that the COVID-19 pandemic is probably at a transition point, and that we need to navigate this transition carefully and mitigate the potential negative consequences. Okay, that's WHO speak. Can I get you to translate that into English for the rest of us?
Sure. Yeah, I think it's really important. This term PHEIC, or the Public Health Emergency of International Concern, when it's activated, it provides the WHO additional resources, both in terms of administrative resources, of funding resources, human resources, to work in terms of organizing its surveillance systems, organizing the work between countries to ensure that if new variants are emerging, that we can know about them quickly, if there are new surges, that we can know about them quickly. And I think that isn't really in place yet. And I think this sort of continuation of the PHEIC at the WHO level allows them a little bit more time to, I think, finalize those things. And I think that's an important distinction between the PHEIC as an administrative tool and whether it's an emergency for people, you know, for in terms of their day-to-day lives, which I think are two very different things.
Okay, understood. But do you think we are still in the midst of a public health emergency?
I mean, I think so. I think it's a really important element. You know, COVID will continue to represent a priority for public health departments at the municipal, provincial, federal, and international levels forever. I think similar to the work that we invest in influenza every year, COVID now is another virus in our ecosystem of viruses that we have to respond to. And I think, yes, in that sense, you know, in the shelter system, we continue to have, we've sadly had somebody pass away just a few weeks ago of COVID. You know, we've continued to occasionally send people to the hospital related to COVID. It's obviously very different than it was, but I think in terms of, from a clinical perspective, from a public health perspective, it will remain a virus that we have to respond to. But I think it's really important to say that, you know, what I tell my family is that I don't think that they have to situate their entire lives around this virus anymore. I don't think that they have to kind of plan their lives around this virus. They are protected. We've had, you know, vaccines. We've had now most people get infected by COVID. And so I think that, you know, the way that they live their lives, they should make sure that they're taking care of their other health issues and also enjoying themselves in the way that, you know, we do as human beings.
Let me pick up on that word protected that you just used, because presumably you think that everybody should have as many shots and boosters as is required. If there are some people out there right now who have still only had 1 or 2 shots, you know, is that what's your view on how protected they really are at the moment?
Sure. I mean, I think at this point there's a really solid understanding that hybrid immunity, so I think it's a relatively new term, but we're calling immunity that is resultant from both the vaccine as well as from having had the infection, is really strong in terms of protecting you from severity, protecting you from going to the hospital. And I think at this point that represents the vast majority of people. And so I do think that most people are protected from going to the hospital. We do have folks that I see regularly that are on disease-modifying drugs from autoimmune conditions that are otherwise immunocompromised. And those folks, we really do encourage them to stay up to date on their vaccines. And so for some of those folks, that means as little as every 3 months between doses. But I think for the vast majority of people, you know, having had 2 or 3 doses plus an infection is providing really sustained protection from going to the hospital. But I will note it's probably not going to protect folks from getting infected. And so if folks are testing themselves regularly, if they're having, like a mild upper respiratory tract infection, they may very well test positive for COVID at some point. But that, I think it's important to separate that from what we had as when, a COVID infection really meant a very high chance of going to the hospital, or a very significant chance of going to the hospital for many people.
Mm-hmm. And if people haven't had any vaccines yet to this point, and somehow they end up seeing you, do you, for lack of a better expression, do you waste your breath on them at this point, or you just assume there's no point in trying to convince them that ship has sailed?
It's funny, I see a lot of people who haven't been vaccinated in the shelter system, and I think that is as a result of sometimes mistrust of government. It can be mistrust of the system. I don't think that it was wasting breath. I always talk to them. I've been doing that from the beginning, and some folks, they absolutely don't want to talk about it, and that's okay. I don't judge them for that decision, as I don't judge them for sometimes other health conditions or other health decisions that they make. So I think it's important to sort of change the frame. I know often there's been a sort of a blaming frame for folks who haven't gotten vaccinated. I would turn it around. I use it as an opportunity. Folks sometimes will change their minds, or they don't. And I think it's important that we don't, disengage from those folks, because they may have other health needs, whether it be influenza vaccination, blood pressure control, diabetes control, mental health, et cetera. And so, indeed, I'm always up for a conversation with anybody who wants to have it.
Okay. Let me pick up on another word that you used a few moments ago, and that word was forever, as in this thing is going to be with us forever. In which case, if that's true, how does this public health emergency eventually end, or does it?
Yeah, I mean, I think that's the separation between, like the sort of the administrative or the responsibility of public health departments, where the response to COVID will never end. I think that's just an important thing. And I think we understood that very early, that this virus, given its properties, given animal reservoirs and people who don't know that they have it, and the vaccine's not protecting from infection as much as severity, we understood that this was something that was never going to be eradicated or even long-term eliminated. And so I think that's an important element. That's not good news. That's just being pragmatic and realistic. I think public health departments require the resources. So, for example, in the context of this emergency in the United States, the emergency is really tied to resources. And so, the idea of access to vaccination, access to treatment is all related to it being a state of emergency. In Canada, similarly, a lot of our investments as it relates to COVID, whether it be wastewater surveillance at the shelter level, which is very useful to us, outreach vaccination service, which is very useful to us, is all sort of ending in the next couple of months. And so I think what we need to start doing is disentangling this idea of, is it a day-to-day priority for the average person, and is it a priority for public health departments? Because they require additional resources that will need to be sustained moving forward for COVID. But I don't think that the average person who has this protection really needs to worry about COVID day to day and make it one of their priorities that they, sort of wake up in the morning thinking about and then go to sleep thinking about.
Well, that may anticipate my next question, because I just wanted some clarification on the World Health Organization's use of the word probably, as in we are probably in a transition period. If that's the case, what are we transitioning from and to?
Sure. Yeah. I mean, I think what they are seeing right now in terms of, there's still, let me just say one thing. I think, the WHO reported a number of people dying every week from COVID in that. But I think it's really important to say that there's not yet a standard in terms of how we attribute mortality related to COVID. So I think that's like one of the things that they're continuing to work on in this transition period. It's just like standardizing the definitions that we use for COVID-related mortality, COVID-related hospitalization, surveillance for new variants, and other elements. And so I think that they are transitioning to having that be really codified, having a solid understanding of that, as they do for influenza. There's a really well-established system that's been ongoing for decades as it relates to influenza. I think that's what they're transitioning to. But I also think it's really important that we be pragmatic with the population to say that COVID-19 won't go away, that I think it will continue to be something that can cause people to get sick, whether that be mild, moderate, or even severe conditions. And the best protection from that, obviously, are the vaccines that we have access to.
I gather you have said that we still have massive systemic problems as it relates to COVID-19 that we are continuing to ignore? Like what, for example?
Sure. Well, I think, we've just published a paper from Ontario showing, and I think this was understood early, that in the first few months of COVID, it affected sort of higher income folks. These were folks that were coming back from Switzerland, coming back from the US, in that sort of January to March 2020 period. But it very rapidly, as does influenza and other conditions, transition to sort of local transmission related to those folks that in the context of lockdowns continue to be out working and serving, society as needed to be. Because I think without them, without internet working, without groceries being there, things would have imploded very quickly. And what we saw was even those early waves that we saw much higher levels of morbidity, mortality, and infection in those in lower income communities. But what's interesting to me is that that's actually the same as it is now in 2022. When we looked at this, we still see lower income communities more affected. And it's not all related to vaccination. It's related to workplace exposures in shelter settings, in Amazon factories, people who use transit more. All of those things are related to infection risks that I think are really important to pay attention to. And I don't think that we've sort of sustained those investments. A lot of the hotels, for example, in Toronto that we use as isolation sites, tourists have come back to Toronto. They now are opening back up as hotels serving tourists and visitors. And so I think it's really important that we continue to make the investments in folks' working and living conditions that are going to help protect them, because we just haven't done that to date. In a place like Ontario, where I think we really consider equity and justice as really central to our society.
So what does that actually look like on the ground?
I think what that means is, for example, in shelter settings, we still have people sleeping 25 people to a room. And I think over the long term, we need to do better with housing programs in order to make sure that they aren't at sustained risk. In a place like that, when somebody is mildly sick, it spreads to everybody within a night, and it's really hard to prevent. We have an isolation site, a single isolation site that we use, but it's really hard to get folks to not all be affected. And again, it can cause tremendous mortality. I think in places like in these Amazon factories, I think they need to really bring in occupational health services and really think about how are the ways that we can make sure that folks are protected in their homes and in their workplaces. Again, and some of that is absolutely outreach services with vaccination programs and really encouraging folks. Some of it is also absolutely upgrading ventilation systems, looking at safer, cleaner air. And so I think it's just about bringing folks in and really thinking about this systematically. And what are these sort of systemic barriers that continue to put people in hospital related to COVID? Because I think if we do those things, I think we can really improve, COVID outcomes for the next 10 or 20 years as compared to just thinking about this sort of day to day.
Well, let me pick up on that, because, of course, the COVID-19 that people may contract today is certainly not the same COVID-19 that they might have contracted 2 or 3 years ago. Do we know enough yet about the level of immunity people can get through the mixture of vaccines and previous exposure? Do we have an adequate amount of information about that yet?
I mean, I think collectively, so we've published on this, I think others have. I will say this, that COVID is the most studied virus in history. It's the most studied health condition in history. I think at this point, there's been almost 400,000 papers related to COVID. So I will say we have a lot of information that we can work with. And I think the best information that we have is that people who have had infection and who have had vaccines are really well protected. But I also think it's really important to say that there are folks that are immunocompromised that require ongoing vaccination and may require additional sort of protections that would include high quality masks for themselves to make sure that they're protected from these settings. So I think that's an important thing, that we in modern medicine can't protect everybody in the same way. And I think we need to sort of make sure that those folks have additional services in terms of outreach vaccination, encouraging them, those folks that are in high exposure occupation, again, going out to them, having those outreach services, or at least making sure that when they're seeing their family doctors, that they, that they receive protections via management of their chronic conditions. So one of the things that we know, for example, is that people with uncontrolled diabetes, uncontrolled hypertension are more likely to end up in hospital from COVID. People with uncontrolled chronic obstructive pulmonary disease can end up in hospital from COVID. And so I think what it speaks to is like we have to do better with linking people to family doctors, moving away from walk-in clinics. All of those things that are sort of central to our health system are actually also going to improve COVID outcomes.
And is there any reason to believe that vaccines might actually become more efficacious as time goes on?
I think that's a fair question. I think there's a lot of production of new vaccines as we speak. I think there was something like 100 products being evaluated. I will say that I think for the vast majority of people, the mRNA vaccines, especially for older, more immunocompromised people, have provided great protection. And I'll say, you know, in the pre-vaccine era, when we were responding to outbreaks in the shelter setting, we would have huge outbreaks and we would send large numbers of people to the hospital. You know, it was immediately different. We started vaccinating in about January of 21 in the shelter setting. And you could immediately see that the shelters that had been vaccinated, even if there was an outbreak, it was unlikely that we would send people to the hospital. And it just was a very different dynamic. There was much less transmission overall. And so I think that the vaccines may get better. Obviously, you know, pharmaceutical companies are actively working on this. But I do think that we have the vaccines, the original vaccines, even the wild-type vaccines are providing great protection. Again, in the context that now most people have also been infected with COVID. Not everybody.
Okay, let me drill down a little deeper on that one because, of course, again, going back to this theme that the COVID of today is not the same thing as the COVID of yesteryear. We have different strains, we have different subvariants, we have different subtypes. How concerned are you that whatever vaccinations are being produced right now or in the future may not actually be as effective because this thing just keeps mutating all the time?
Sure. Yeah, I mean, I think it's really important to say, you know, I don't pay as much attention to the variants in a broad sense, like in a day-to-day sense, as some other folks. I think that this is a virus that will continue mutating and changing over its lifespan, similar to influenza and other coronaviruses. I don't think we've ever sequenced other coronaviruses this closely. So, you know, while we have these traditional waves of coronavirus, sort of the sort of seasonality of coronaviruses, we've never sequenced it this closely. And so but I think that we would see that it also was full of new variants, you know, every year affecting us. So I've sort of separated that idea from, you know, this idea of like what is putting, you know, ultimately for me, it's what is resulting in somebody going to the hospital. And I just don't think that with these new variants that we're whether it be the virus changing or just us changing in terms of increased immunity, we're just not seeing the same level of hospitalization. And that can change. And if it does change, then I think we have to react differently and act differently. But we've not seen it change anywhere in the world, ranging, you know, from I should say outside of China, where they've just sort of had their initial waves that we experienced a couple of years ago. We've just not seen the places that have already had these large waves have large waves that have resulted in significant morbidity and mortality, which I think is what most people are paying attention to.
So in our last 30 seconds here, is the long-range plan to have COVID become just like the flu, where basically we know it's coming every year, we're going to get our fall shot or our winter shot, and life goes on?
Yeah, and I think it's really important to say, so broadly, yes. I think that the same way that we see public health responding to influenza with their seasonal campaigns, we are going to see them saying like it is influenza and COVID season. I think this question about annual shots is something that we need better research for. We have that research for influenza. We need to ask that question, whether that is going to result in the same sort of benefits for people. But broadly, yes, public health is going to have to react and respond to COVID. I think maybe I'd say unfortunately, but realistically for as long as we all are alive.
Gotcha. Dr. Stefan Barral, we are really grateful that you could spend some time with us, taking you away from your vacation to share this very important information with our viewers and listeners. So thanks so much.
It was a pleasure. Thanks for having me.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.